Hi, this is Katrina Anderson, and today we're going to talk about pulmonary disorders with an emphasis on the lower respiratory tract. So we'll be covering asthma and COPD, and then acute bronchitis and pneumonia. So our first two will be obstructive, and then our second two will be looking at infectious diseases. Okay, so for asthma, basically it's chronic inflammatory disease of the airways. So in the U.S., it affects about 24 million people, with a heavier emphasis on women and children of that amount. And then we have over 5,000 deaths annually from asthma alone. So even people who have mild forms of asthma, anybody has a chance for having an acute attack. So this is something that we do want to be paying attention to, particularly in the primary care setting. So increased prevalence among inner city residents, racial minorities, people who have a low socioeconomic status, and then women and children, like I said. So asthma is characterized by obstruction as well as inflammation due to airway edema, bronchoconstriction, mucus plugging, and airway wall remodeling. That remodeling happens over time and does put women at a higher risk for being vulnerable to lung issues later in life. But in general, when we're thinking about asthma versus COPD, we think of asthma as reversible airway obstruction, whereas COPD is chronic. So adult onset asthma can occur in a variety of settings. Allergens definitely play an important role in asthma. So IgE antibodies primarily for thinking about allergens, and oftentimes there is a family history. Occupational exposure to workplace materials can really cause more inflammation and exacerbate it. Hyperresponsiveness essentially is our issue for causing our signs and symptoms. So clinical presentation, we have recurrent episodes of cough and wheezing. Oftentimes chest tightness would accompany that, shortness of breath. They might notice the wheezing, and then they may notice it particularly with exercise or activity or when they're exposed to particular allergens. And sometimes they'll present with a cough and no wheeze, so that's something to be aware of too. Sometimes people will present with really thick, clear mucus that they're constantly coughing up, and they might not have even had an attack per se or a wheeze per se. So something to keep in mind, particularly with people who have chronic coughs. So thinking about medical history, we're talking about any symptoms that they might have had, any kind of pattern, especially if it's a family history of asthma or other types of allergies, eczema, that kind of thing. Assess the severity of the asthma, and then identify any possible precipitating factors, whether that's exercise or whether that's seasonal allergies that accompany it, every time they visit their grandma's house and are around the cats a lot, whatever that looks like. And sometimes it's switching pillows, switching laundry detergents. So asthma physical exam, we're doing an upper respiratory tract, so we might notice rhinitis, nasal polyps. I'm looking at the chest. Are there any chest retractions? Do they have a barrel chest? That would be more common with COPD, but these are all things we're being mindful of. And then skin, are there any rashes? Do we see any eczema? Atopic dermatitis? So pulmonary function tests are basically going to be the pillar for our diagnosis. And this isn't typically done in a primary care setting, so you would be referring somebody out to a pulmonologist for this. But you could certainly be following somebody long-term with their asthma, generally speaking, once it's already been stabilized. So if you suspect that somebody has it, then you could send them to a pulmonologist, and then once they're kind of set up, you could certainly take over management and be the ongoing person who's managing their asthma and who's refilling their prescriptions and checking in on how they're doing annually, that kind of thing. So that could certainly be part of your role. So when we're looking at spirometry, we're thinking about the forced expiratory volume. That would be in 1 second is the FEV1, and then forced vital capacity. So when you see what the results are, what you're wanting to do is compare it to other people who are the same age, height, sex, and race. So it really is tailored based on what their demographic is, what we would expect to see, particularly with the elderly. Oftentimes the elderly are misdiagnosed because they're not compared to their right age group. So generally speaking, spirometry would be done at an initial assessment, and then once it looks like treatment has stabilized symptoms, and then every 1 to 2 years, this can be done again. So we can use the peak expiratory flow meter to manage how somebody's doing over time. And basically the take-home message here is that we want to measure how they're doing compared to the patient's personal best. So they're their own baseline in that respect. So we can make sure that our treatments are effective based on that. So asthma, basically there's different things that can cause it to be more severe or not. Certainly if there's rhinitis or sinusitis on top of the asthma, that would exacerbate it. Any kind of upper respiratory infection, GERD has a strong link with that as well, and then sensitivity to certain drugs can also play a role in that. So differential diagnoses that you want to consider. So underdiagnosis is pretty frequent with asthma, and then there are recurrent episodes of cough and wheezing. It's almost always going to be due to asthma, so that's what we want to think about first and foremost. But COPD would be an option, heart failure, mechanical obstruction of the airway, cough secondary to ACE inhibitors, vocal cord dysfunction, all of those should be in your differential list. So therapy goals for asthma, we want to prevent chronic as well as current troublesome symptoms, such as attacks, maintain normal, take out the extra normal there, sorry, peak flow, and then maintain normal activity. So whatever kind of exercise they're used to doing, we want to be able to keep them in the game. So, wanting to help them maintain their normal activities of daily living. And then prevent recurrent exacerbations of asthma and minimize the need for emergency department visits or hospitalizations, since that can be one that really clogs up the ED. So for asthma, for pharmacologic management, there's two basic categories. Basically our long-term control, which is our prevention, and that's going to be the staple here. We want them taking something daily that's going to keep attacks from happening in the first place, rather than just relying on our quick relief rescue meds. So long-term control could be corticosteroids like Flovent, long-acting beta-2 agonist, so you can see them there. And then quick relief would be our short-acting beta-2 agonists, are most common, like albuterol, anticholinergics, which you also see with COPD, and then systemic corticosteroids would also be an option if it was really acute. So this slide is really busy, but it is really a gold mine. So how are we classifying asthma severity? We can classify it as either being intermittent or persistent, and then if it's persistent, it can be mild, moderate, or severe. And I have slides for these coming up, but really this has everything that you need here. So intermittent would be less than 2 days a week, and then at night, less than 2 times a month, where they're waking up with symptoms in the middle of the night. And then the short-acting beta agonist, so that rescue medication, they're needing it less than 2 times a week, and it's not interfering at all with what they would normally want to do for the day. And then this gives you an idea for when they do spirometry, what it's coming up as. So that in comparison with mild then is more than 2 times a week, but it's definitely not daily. So anything between 2 times a week and daily would be considered mild persistent asthma. Nighttime awakening about 3 to 4 times a month. And then they're needing their short-term, that rescue medicine, they're needing that more than 2 times a week, but again, not daily. And not more than 1 time in a day. So you can use this as a good reference form. And then mild intermittent asthma. So this would be our less than 2 times a week, less than 2 times of nighttime awakening a month. Basically, all we need to do treatment-wise here would be some kind of a quick reliever rescue med. So albuterol, for example, or cromolyn sodium would be another option there. You could do that before exercise. And then just being mindful of cold temperatures and allergen exposure and educating around that. So generally speaking, if they can't tolerate albuterol and albuterol side effects, then that's when you might consider cromolyn. Otherwise, albuterol is basically our staple there for rescue med. Okay, so then mild persistent, we're getting into the persistent categories. More than 2 times a month, but not daily. Treatment, we want to give them their rescue medicine, right? So they have that on hand if they need it, but we don't want to rely on this. So this is when we want to do a once daily controller medication. So that can be an inhaled corticosteroid or a leukotriene modifier. We don't want them using this too much. We don't want them to be dependent on a rescue med. We want to get a controller medication on board if they're having symptoms more than twice a week. Then moderate persistent asthma. This would be when we're having symptoms daily. We definitely would want our controller med, and then we'd probably also want a leukotriene modifier, so we're looking at adding on a second controller med. So an example there would be Singulair, and then also having a rescue med on hand if we need it. Severe persistent asthma then is when we're having continuous symptoms, frequent exacerbations, frequent nighttime symptoms, and it's really limiting their activities of daily living. So needing multiple daily controller medications and then also having their rescue inhaler. Okay, so asthma patient education, basically talking a lot about adherence to the regimen, so not wanting them to rely on the rescue medication, but making sure they understand the importance of the controller medications. Talking about inhaler technique and making sure they're understanding all the education around that well. Maybe using a spacer, what that looks like, especially if their technique isn't great. A spacer would be a nice addition there. That they're understanding side effects of medication. So with the beta agonist, nervousness, tachycardia, sometimes that will accompany it, which is why sometimes the cromolyn is a nice substitute if that's too hard. And then symptoms and activities. So basically that we're wanting to get them to a place where they can do their usual ADLs. Asthma referral. So at what point would we want to think about referring a patient with asthma? If they've had a life-threatening exacerbation, requiring continuous oral corticosteroid therapy, unresponsive to therapy, maybe additional testing is needed, maybe they have GERD that's uncontrolled, any kind of underlying allergy component would probably be worth referring to so that could be further worked up. So it's that overall clinical picture. And then for those of you who are maybe at sites that don't do a whole lot of primary care, probably for you, asthma is going to be to just make sure that they're in a good place, which the best questions to ask there is just how often are you using your rescue inhaler? And I see that you have a prescription for taking one of the long-acting controller meds. Are you doing that every day? So those kind of questions get at how well controlled it is. And then for those that are well controlled, just continuing to refill their prescriptions. And then if people are getting out of balance, perhaps doing some of that management, but then based on your site and based on your comfort level, perhaps referring, particularly if they're unresponsive to your initial therapy. Okay, so we're going to switch gears and talk about COPD. So 16 million in the US, so not as many. And I have the stats here for males versus females, though actually I think that's starting to get just a little bit outdated. Women are catching up to men. The number of people with COPD is increasing, especially among women, so I guess I was speaking to that a little bit there. Fourth leading cause of death in the US, and it's the only major health problem in which mortality has been increasing over 20 years. So for those who are diagnosed with COPD, over half of them will die within 10 years of that diagnosis. So COPD, basically, I don't really like any of these definitions very well. Let's see, we'll go to this last one. So airflow limitation is getting at that obstructive piece. It's usually progressive, and it's associated with an abnormal inflammatory response to the lungs from noxious particles or gases, which most commonly is smoking or nicotine. So actually, I'm going to go back for just a sec. So COPD, when we think about COPD, it's basically a combination of both emphysema as well as chronic bronchitis. And usually it's not purely emphysema or purely chronic bronchitis so much as going kind of back and forth between the two, but it has a lot of elements of both. So emphysema, we're going to think of them as our blue bloaters as opposed to chronic bronchitis we think of as our pink puffers. So if that gives you an image of kind of what's going on. So emphysema is defined as abnormal permanent enlargement of the air spaces distal to the terminal bronchioles. So, so basically it's really hard to get the air out of the lungs. And it's accompanied by destruction of the pulmonary wall there. So then we have a lot of action of neutrophil enzymes, so that inflammatory response, and it results in progressive hyperinflation of the lungs, and it's never completely reversible. So chronic bronchitis are pink puffers. So we have narrowing and obstruction of the airway. So emphysema is we can't get the air out, and everything is hyperinflated distal to the bronchioles, whereas here we have narrowing and obstruction of the airways for chronic bronchitis. And again, it's that inflammatory response. So technically, chronic bronchitis would be defined as having these symptoms for 3 months out of the year for at least 2 years in a row. So that's the definition of chronic bronchitis at the end. And the symptoms being a chronic, recurrent, productive cough. So bronchitis is going to have a productive cough, whereas emphysema, sometimes it's dry. Risk factors, but again, all of this is in the context of COPD, which could be more emphysema, more chronic bronchitis, or a little bit of both, going back and forth. So risk factors, smoking, that's your #1 risk factor. So for smokers, the typical onset is in the 30s, whereas for non-smokers, it's generally in the 40s. The older you get, the more likely you are to develop COPD. Air pollution and occupational factors can also play a role. So it's kind of all of that together. So cigarette smoking, it releases oxidants and free radicals, increases neutrophil population in the lungs, it suppresses elasticity. So all of those factors make smoking our #1 risk factor then for COPD. So you can see that by age 35, we our FEV starting to decline, and that rate would be an even faster decline if somebody smoked. So if somebody chooses to quit, then a small amount of lung function is immediately regained, and then the longer they stay quitting, they'll continue to regain just about as much as they lost for lung function as if they were never smoking. So the longer they stay quitting, then the closer we get to what our baseline was before. So that's encouraging. COPD clinical features, typically we have smokers, so mean of 20 cigarettes a day times 20 years. So that's the average for somebody with COPD. Usually presents in the 5th decade of life, and it's a productive cough or acute chest illness is how we're first figuring it out. And the dyspnea on effort begins in the 6th or 7th decade of life. Comorbidities, pretty common to also see weight loss, nutritional abnormalities, skeletal muscle dysfunction. Not uncommon to also see comorbidities like having an MI, osteoporosis, respiratory infections. So this oftentimes accompanies other things. So let's just pause for a second and think about asthma versus COPD. We know that they're both obstructive respiratory disorders. So asthma typically is starting out earlier in life versus midlife for COPD. And then asthma, our symptoms can vary day to day, and it's immediately reversible, right? So when we have an attack, we go back down to baseline once it's over, whereas with COPD, it's slowly progressing. Asthma, you can have symptoms at night and in the early morning sometimes that are particularly rough, whereas that's not necessarily, COPD, we don't see that connection. And then allergies, rhinitis, and or eczema oftentimes are present with asthma, so a much stronger link with asthma, whereas with COPD we think about smoking as being our strongest history link there. And then asthma has a stronger family history tie as well. And again, that reversible piece versus irreversible airflow limitation. Great. Okay, so history taking for COPD. We're asking about smoking, we're asking about environmental exposures, and then thinking about symptoms associated with emphysema and bronchitis. So we're asking about dyspnea, asking about their cough, how long they've had their cough, is there sputum with their cough, is it worse in the morning, etc. And if they ever notice any blood when they're coughing. Early findings, we might see tobacco-stained fingers, so yellowing of the nails, lung sounds, wheezing, coarse rales, rhonchi, prolonged expiratory phase respiration because it's hard to get all the air out with emphysema, right? And lung sounds might sound distant or faint when you're listening. You might notice barrel chesting as well from all that lung expansion, especially over time. And then later findings, you might notice them sitting in a tripod positioning because it's harder for them to breathe otherwise. So using more accessory muscles to breathe, pursed lip breathing, cyanosis, heart failure. So these are all probably pretty familiar. You could think about doing a chest x-ray if you needed to exclude other diseases. And then thinking about blood work too, you could consider doing a little bit of blood work. Probably you wouldn't be working somebody up with COPD for the first time, but certainly, I mean, if people have been seeing us for a long time for their annuals, we might be the first ones to pick it up. So doing some of that initial diagnostic testing, and then wouldn't it be uncommon for you to refer them out for their full initial startup management plan, but then you could continue the plan that is started by the pulmonologist from there, certainly. So management of stable COPD, so that's more likely what we would encounter, right? So spirometry should be performed following administration of adequate dose of short-acting inhaled bronchodilators to minimize variability. So they're taking the bronchodilator before we test it so that we can see what is their baseline with the bronchodilator. And so if our FEV1 and our FVC are less than 0.7, that confirms the presence of airflow limitation that's not fully reversible. So it would be not fully reversible already having the bronchodilator on board. And you want to make sure again that we're comparing that to age-related normal values to avoid overdiagnosis of COPD in the elderly. Okay, so patient education, we're talking about what is this? Why are they having certain symptoms, the purpose of their medications. Counseling on risk reduction is huge. And we'll talk just a little bit about smoking cessation here. Nutrition, I had mentioned weight loss often accompanies COPD. So there's a few thoughts for why their nutrition can be altered. One is that because they're breathing from their mouth so much, they have altered taste perceptions. So they're not eating as much because they can't taste food as well. And then if they do have a lot of air trapped in their lungs, then that can make them feel full sooner. And then depression also oftentimes accompanies chronic disease, and that can certainly affect somebody's appetite as well. So these are all things we're wanting to assess for and come alongside and be providing good nutrition counseling based on what their individual needs are. And with risk reduction in general, thinking about air pollutants, occupational dust, chemicals, what's their housing situation look like, etc. So I know for me there's so many different models for assessing readiness for smoking cessation, but my favorite in practice, I spent a good chunk of time in occupational health. Sorry, I'm a little tired. So in occupational health, and we did a lot of smoking cessation counseling with workers there, and my favorite method to do is to ask these first two questions, to have them on a scale of 1 to 10, think about how ready they are to quit today. And then from there, if they did attempt to quit, how successful do they think that they would be right now? And based on what number they give you, you can kind of know where to take your counseling. So if their answer to both of those things is 1, then maybe just planting seeds around what they think would be motivators for them to quit in the future, or perhaps what do they think might be able to bring them to a 4 by next year. Most people know that smoking isn't great for them. That's no new news, and certainly reiterating that is fine. So as far as being motivators for smoking cessation, that's oftentimes not the best motivator so much as what would positive motivators be. So maybe it's around being able to go to their kids or their grandkids' basketball games without huffing and puffing so much and without feeling too exhausted from the experience to go in the first place or something like that. But trying to think about positive motivators can be helpful. Whereas if you hear that they're, an 8 or a 9, or think if they, if they try today that they would be able to make it happen, then we want to have a much more in-depth conversation about what their options would be, whether we're thinking patch or gum or nasal sprays. We're talking about Zyban, which is the same as Wellbutrin or Chantix, and how can we come alongside them with a more thorough plan. So I always think before I'm getting into smoking cessation counseling that I want to know where they're coming from so that I can target how I counsel accordingly. So I'm not going to get into these in too much detail because I think we probably won't see a whole lot of COPD, but just to be aware that it is staged and that staging is basically based off of their FEV1 and their FVC ratio. And then you can see that symptoms, the more severe it gets, the more you notice that people are having symptoms. So then how much we're doing for management are these bottom tiers here. So we're avoiding risk factors, and then we're also having our flu shot if we're really mild. And then we probably have at least a short-acting bronchodilator for when we need it. So similar to asthma that way. And then you can see that we're adding in long-acting bronchodilators, as well as rehabilitation, as well as inhaled glucocorticosteroids, etc., as we go down the line. And part of that too is just being familiar when you look at somebody's med list, understanding why they're on what they're on, and even if it's just a quick check-in at their annual to understand why they're taking what they're taking, and to be able to check in and make sure that they're following that properly is just good practice. So COPD treatments, again, we have our bronchodilators, so our beta-2 agonist is needed, anticholinergics, and then the anti-inflammatories. Oftentimes they're going to respond better to anticholinergics, just as a side note. So our anti-inflammatories, like they might be on prednisone briefly and then need to be weaned off, so you might see that. Rehabilitation would be exercise training programs that are designed to help improve their dyspnea, improve their fatigue, and their exercise tolerance in general. So that really can be a huge staple for COPD treatment and something we're going to want to encourage, especially if they're finding that their COPD is affecting their activities of daily living. And then oxygen therapy. Basically, we do know that that long-term administration of oxygen, so more than 15 hours a day, has been shown to increase survival in patients with COPD. So realizing that it's hard for them to get all the air out of their lungs, our goal is to maintain their oxygen above 90, so it's not like it needs to be as high as we're wanting it for everybody else, but to know that that's our target there. Okay, so COPD treatments, other things we might see, antibiotics. This would only be used to treat infection, basically exacerbations. So if they then also have a bout of bronchitis, that would be something to consider. Typically bronchitis is going to be viral, but we're just thinking about how our COPD patients are going to be more vulnerable to other types of infections as well. So generally then the drug of choice would be macrolides or amoxicillin, cephalosporins. Vaccines, they should have their flu vaccine annually, and then the pneumovax every 6 years. And antioxidant agents would be an option there as well. And then basically we're not wanting to recommend mucolytic agents, antitussives, or vasodilators. But being aware that acute bronchitis can easily progress to pneumonia in a patient with COPD, we do want to keep a close eye on them if they are presenting with an infection. Okay, so we're switching gears now to do bronchitis and pneumonia. So we've done our obstructive diseases, and now we're moving on to bronchitis and pneumonia. So bronchitis is the 5th most common illness diagnosed in primary care. So this is one you guys are going to see. More cases are in the winter and spring, and it's typically viral, so we're thinking no antibiotics, and it's generally speaking going to be self-limiting. So history taking. Oftentimes it's a persistent cough following a URI, and that cough is generally going to be productive and might have like a clear mucoid sputum appearance. Associated symptoms, you might see a low-grade fever or you might not see a fever, headache, malaise, kind of those general symptoms. Physical exam, you might see a mildly elevated temperature, pulse, and respiratory rate, or they might be normal. Breath sounds, few diffuse wheezes or fine crackles you might notice, and then possible rhinitis alongside it. Some of that can be left over from their URI as well. And then on our differential list, we want to be thinking about pneumonia and then heart failure, drugs, like if they were recently put on an ACE inhibitor, and then GERD. So if you were noticing a higher temp, you'd want to have your ears perked for bacterial infections. But generally speaking, our viral ones are going to be low-grade fever. And if at all you thought this could be pneumonia, you'd want to do a chest x-ray. That's a gold standard for pneumonia. So when in doubt, go ahead and get a chest x-ray. But heart failure, you'd probably also see edema, you'd see a high blood pressure, so it's generally pretty easy to figure out what's what. I don't know if I would say pretty easy, but okay. Acute bronchitis management. So non-pharm would be smoking cessation, right? And then hydration and rest and nutrition. And then pharmacology, antibiotics are controversial. So they're not going to be effective if it's viral, and it usually is going to be viral and self-limiting. So something to consider, but probably not do. But inhaled bronchodilator could be really helpful there. Cough suppressants we generally want to stay away from because we really want them to help them get it out, right? But if it's keeping them from being able to sleep at night, then a cough suppressant might be warranted for that. And then acetaminophen can be used for fever and comfort. So education around bronchitis, we're wanting to avoid antihistamines, let them know the cough might last for 2 to 3 weeks. We're really just wanting them to really rest and increase their fluids to help keep everything moving and get it out. And then follow-up would be to return to the clinic if the symptoms are worsening or if it hasn't improved in 3 weeks. Prevalence, higher in the very young and the very old. Oh, we're on to pneumonia. So switching gears, community-acquired pneumonia. So our young and our old are going to be at the highest risk, more cases in the winter. Most common pathogen is going to be Streptococcus pneumoniae, though certainly H. flu and M. catarrhalis would be number 2 and number 3 there. But majority of cases, 40+% are going to be strep. It's the 6th leading cause of death, and then mortality for outpatient is about 1 to 5%, and then for those that are inpatient, over 20% of hospitalized patients die of pneumonia. And you even just think about, okay, well, maybe they were in the hospital for having had a fall with a hip fracture, but then if they acquire pneumonia in the hospital, that could be what ends up killing them. So really wanting to be mindful of symptoms of pneumonia in our patients. Though we're not really treating the ones that are in the hospital, so I suppose that is not as applicable to our patient population, but just something to be aware of. And if nothing else, a reason to really hit home our osteoporosis prevention pieces when we're in the community. Okay, so presentation, cough could be wet or dry, but you'll see sputum production, dyspnea, a fever, so this is higher than acute bronchitis, right? And now we're thinking pneumonia is more likely to be bacterial also, right? Whereas our bronchitis was generally viral. Though, bronchitis that's not getting better could certainly develop into pneumonia that could be bacterial. So tachypnea, crackles or rhonchi increasing, phrematous, dullness to percussion, pleuritic pain on inhalation, that one's a lot more classic for pneumonia than bronchitis, and night sweats. So what would a workup look like? So our differential list, we'd want to think about acute or chronic bronchitis, asthma, pulmonary embolism, congestive heart failure. For diagnostic tests, gold standard is a chest x-ray. If you're thinking you might have pneumonia, you want to get a chest x-ray. And lobar or segmental consolidation would be consistent with pneumonia. And you want to make sure patients are really well hydrated, because if they are dehydrated, then that can give you a false positive. So when you're sending them off for a chest x-ray, send them with a water bottle too. And then you can draw labs. So the CBC, you'll probably see elevated white blood cells. And the ABGs basically tell you how severe the pneumonia is. So that could influence whether or not you end up admitting a patient, which would then be a referral, right? So that would be a full transfer of care. And then sputum gram stain culture, to do a culture is a little bit controversial, but it could be helpful if the etiology is less common, or to detect any kind of resistance if you've already treated somebody. And it might be a good idea to do it if they already have COPD or other conflicting comorbidities that could complicate their case. Then that could be more worthwhile. Bronchitis versus pneumonia. So just to compare these real quick. So bronchitis, we have more of a gradual onset. Probably they had a URI first. Pneumonia tends to be a pretty acute onset, though certainly a URI might have preceded it as well. We probably have no fever, maybe a mild fever with bronchitis, whereas with pneumonia we have a fever and it's probably pretty high, somewhere in the 101 to 106 territory. And then vague tightness or chest compression we might notice with bronchitis, whereas with pneumonia that's a lot more intense. So breathing in might cause quite a bit of pain. Dyspnea is fairly rare with bronchitis, but fairly common with pneumonia, as well as just our vital signs in general might be slightly off with bronchitis, whereas with pneumonia, seeing tachycardia, seeing tachypnea, seeing the fever, we're more likely to have to look sick and have our vitals tell us we're sick, whereas bronchitis, oftentimes they don't look like they're in apparent distress. So just for thinking about severity. But if you're debating between the two, you get a chest x-ray. That's basically the take-home message there. So pneumonia, we're thinking it's bacterial almost always. And so if we're less than 61, we don't have any other comorbidities, number one drug of choice, we're going to pick a macrolide. And then if they had an allergy or something to macrolides, you could do a tetracycline, like doxycycline, for example. So if they are over 60 and they're, or they have any kind of comorbidity, then we want to think about second-generation cephalosporins or Bactrim, possibly a fluoroquinolone. But this is probably also the territory when you want to think about if they're a good candidate to just stay outpatient or if they might need to be admitted. So also something to keep in mind there. If nothing else, if you've got somebody over 60 that you're treating for pneumonia, you'd want to really keep close tabs on them. So risk factors when we're thinking about whether or not we should admit somebody. What is their age? Do they have comorbidities? Where are their vitals at? Is their temp really high? Is their respiratory rate really high? What's their blood pressure look like? Is it too low? That's more what we're thinking about for blood pressure. What's their level of consciousness look like? Is their white blood count really low or really high? Kind of all that pictures together. And generally speaking, you're probably going to be consulting. If you're debating on whether or not somebody should be admitted to the hospital for pneumonia, that would probably be worth a strong consult. So you have a college-age student coming in, and at first you think it's bronchitis, and then you're like, I think this might just be a little bit too intense. I think we need to check this out. You do a chest x-ray. You find out it's pneumonia. She's got dorm friends willing to make sure that she rests and eats and all of that. It would certainly be appropriate for you to just treat her outpatient if it wasn't too intense of a clinical picture, as opposed to, if you had an older woman present, for example. Then you'd want to have be more willing to send her in. All right, so that wraps it up for thinking about the lower respiratory tract and different diseases there. So hopefully that's kind of helpful to have a verbal overview, but certainly your book is a great overview too. So for all of you visual learners, I will leave you to that as well. All right, have a good day, everybody.